We are so glad to have you with us today. I could not be happier to have this group. They are definitely the experts in this field. We are having a presentation today, live vaccination and transplant recipient kids. I know there have been so many questions with this, and so we are so glad to have everyone with us, and especially our esteemed experts. With that, it is my pleasure to introduce the person that had this idea, and I would say person or persons. So I will go ahead and go forward to give Jen Lau, and she is with Bear, and I would give you the floor to introduce yourself.
Hi, thank you so much, Melissa, and I'm so excited. Always grateful for this partnership with Transplant Families, and so grateful for the panel of experts today to be able to join us and to just give their expertise and share with the community on such an important topic, especially in today's environment. So I wanted to share just a little bit about BEAR, which is the Biliary Atresia Research and Education. And biliary atresia, a lot of our families are touched by transplant because a liver transplant is in fact the main treatment for our kiddos. So I just wanted to just briefly just kind of go over just some of the programs that we do offer for our families since we've truly only have been around for a couple years. We started in 2022. And so first and foremost, we support families in biliary atresia pre and post liver transplant, and some of the other programs that we do, host for our families is a connection network, the Bear Connection Network, where we connect families all across the United States, Mexico, and Canada now. We also advocate and have been advocating recently with early detection and newborn screening for biliary atresia babies. We also host yearly our scientific and patient and family symposiums on all the new and upcoming topics within biliary atresia and liver transplant, mental health, and other topics within that touch our communities. We also have a patient registry. And also just starting this year, we started a Bear on the Road, which basically allows us to visit participating centers and visit our patients and families and have robust conversations as to what our families are seeing, what our families need, and also what our centers need as well to help support those families. So that's just a little bit about what we do within our community. Next slide. This is just our contact information. You can also visit us on our website, which is bearinc.org. But there's our email address, our social media. Facebook, you can just look us up. I really don't know if Facebook has a handle or not. I'm not that technical. But you can find us there. And once again, I truly want to just thank everybody for joining us today and taking their time out of their hopefully your summers have started. Everybody's out of school. And I will toss it back over to Melissa. And thank you again.
Thanks, everyone, and thank you, Jen, so much for this. It's been wonderful to see Bear and how you've grown so much. It's just a really wonderful organization. I encourage everyone to go check them out. And of course, you know us, we're Transplant Families. These are our programs. We have a Caregiver Connect for families. If you just want to talk it out with other transplant moms, we do that monthly, the second Tuesday of every month. We have lots of educational resources, workshops. We do those in conference and throughout the year with webinars, these that we often collaborate with other wonderful groups with. We have community outreach events, networking opportunities for family, and patient-centered research that we're involved in and embedded with a lot of really great groups. And you can check us out at these social media outlets. So you can Facebook, Twitter, Instagram, LinkedIn, Blue Sky, and our website, of course, with transplantfamilies.org. or you can email us at hello@transplantfamilies.org. Now, with that, I am very privileged to be able to make introductions for the live viral vaccination and transplant recipient kids webinar. And we will start off first with Lara Danziger-Isakov, Director of Immunocompromised Host Infectious Diseases at Cincinnati Children's Hospital Medical Center. And then we will follow with Amy Feldman, Medical Director of Liver Transplant Children's Hospital Colorado and split President-elect. And we will finish with Ann Dipchand, Medical Director, Heart Transplantation for Sick Kids Toronto. And I am so excited to be able to see this presentation. Thank you, Laura, for starting this off for us.
My pleasure. Thank you. Thank you for inviting all of us to do this, because we're really excited to share this information and just give people a little bit of peace of mind and some context and the place to ask questions, because we know there are a lot of them. You can go to the next slide. We're going to start off with a quick presentation. This is a theoretical person, 11-year-old who had a heart transplant at 1 year of age for dilated cardiomyopathy. They present with an erythematous macular papular rash and white spots in their mouth. They have a positive measles IgM and a positive throat swab by PCR for measles, and they're admitted. Their immunosuppression is held. They get vitamin A, and they're in the ICU. They end up being ventilated for 2 weeks, including 3 total weeks in the ICU and 4 weeks in the hospital. And you can see this is just an example of some of what the rash and the spots in the mouth look like. That's the inside of the cheek. Those are called Koplik spots. Okay. And, we could go back a little bit and say, prior to transplant, Bobby had gotten their routine vaccines, but no 12-month vaccines and no live vaccines. And currently he's 10 years post-transplant. The only medication that he's taking are tacrolimus and MMF or Celsec. And his tacrolimus range is 5 to 8. He has low MMF troughs, and he has not received any live vaccines post-transplant. And the question that we often get, was there anything that could have been done differently in advance of contracting measles for this young man, so that we could have avoided the complications related to measles? And we want to talk a little bit about that today. I always like to give people a little bit of a background about measles in the US. Technically, measles was quote unquote eliminated in 2000 in the US. This means that it doesn't exist. It means that there haven't been any cases that came just from in the US. So if you can bring a case in externally, they're called imported cases, and cases that are being associated with the virus being imported from outside of the US. And that is why it was designated as eliminated. Now, that means that we still do see cases, usually less than 140 cases per year across the United States. But over the last several years, you can see that we've been accelerating these quote unquote outlier years where we have more cases than 140. And as most of you know, already this year, we have more than 1,000 cases in 32 states in the District of Columbia, including 2 cases in children who got measles and unfortunately died. Both of these children were unvaccinated. And so that is a risk factor for death if you do get the measles. Now, the majority of patients did not, and that's really also important as well. The majority of the patients who've gotten measles were unvaccinated, but there are some who had only received 1 vaccine. So that's important to remember as well. Go to the next slide. Why is this happening, do we think? Well, there is something called herd immunity, where if you have vaccinations above a certain level, usually somewhere around 95 to 98%, or 90% at the lowest, that it's unlikely that you're going to have spread of the measles in a wide range. But you can see currently over the past several years, there have been lower, you can see the lighter blue areas, lower vaccination rates than we target. And this leads to the people being at risk for infection should they become exposed, and also increases the risk of it spreading because there's more people who could be potentially get it. Because a significant portion of the people, for every 1 patient with measles, they can infect up to 18 people on average if they are around people who don't have protection from vaccination or prior disease. Next slide. So MMR vaccine, just to let people know, is only available starting, you have to be at least 6 months of age, right? If you get vaccinated before 12 months of age, it doesn't count toward the 2 vaccines that are considered for your attendance at school. Historically, we have not given live vaccines after transplant due to the concern for having a vaccine-related issue in an immunocompromised child. And between 1994 and 2022, there were 4 patients who had severe life-threatening measles following a vaccine. These were patients who had immunodeficiency, who had untreated HIV and cancer. And you can see that this is a very, very rare event. Next slide. Now, in 2019, a group of people, actually including Dipchand and myself, were part of a consensus after there had been some early studies from Switzerland, as well as some retrospective studies, which means studies that looked back at people who may have gotten vaccine, and showed that there was a group of patients after transplant who could safely receive vaccine. The majority of these studies looked at liver transplant recipients, looked at patients who are on very low doses of immunosuppression. Based on that, this group of experts that included infectious disease physicians, immunologists, transplanters of kidneys, hearts, livers, lungs, adult infectious disease providers got together and actually talked about what might it look like if we were to think about who could get live vaccines after a solid organ transplant. And we came up with a very kind of crude but illustrative model where you think about vaccinating patients who fit the profile of the patients who had been vaccinated in very well-controlled clinical trials in the green. Caution pushed the limits a little bit to who else we thought would be unlikely to have a severe event, and the deferral was patients where we just didn't have any information. This led to the ASTI-DCOP 2019 guidelines, where it was a new recommendation that selected patients with education and close follow-up could receive varicella zoster vaccine, and selected at-risk patients during an outbreak could receive MMR vaccine. Now, these guidelines are currently under revision and will move the needle even further based on some of the information that Dr. Feldman is going to share with everybody. Next slide. So I'm going to turn it over to Dr. Feldman now.
Thanks so much. So as Lara was just talking about, we were kind of in the midst of a world where we were starting to ask ourselves and starting to see some evidence and some guideline changes suggesting that maybe it wasn't the right thing to always tell transplant recipients that they couldn't get live vaccines. Maybe the risks and the benefits had shifted. And at the same time, a lot of you all were asking us about live vaccines and wanting to know if your kids who were going to college and traveling and going to Disneyland could maybe get their live vaccines. So Lara and I decided to pull colleagues together in order to study this a little bit better. So the way that we were able to do that is through a collaboration between 2 organizations that you all may have heard of. So the first is PIDS, which is the Pediatric Infectious Disease Society. And the second one is SPLIT, which is the Society of Pediatric Liver Transplant. We asked centers basically if they were wanting to and willing to vaccinate certain of their transplant recipients. And then what we wanted to do was to collect information to understand both the safety of giving live vaccines after transplant, as well as the response that children had to live vaccines. In our world, most research has to be funded, but this is really unique in that this was totally unfunded. So providers, physicians, nurse coordinators, research assistants really did this kind of out of wanting to do what was right for their patients and dedicated their time and their resources for free. So just to really explain how this study was set up. So giving vaccine was not the research study. We left that up to every single center to decide who they wanted to offer vaccines to. What were their criteria? The part that was research was just collecting the de-identified information about how children responded and did they have any safety issues. And just to reiterate, each center determined who were the children that they were going to offer a vaccine to. Next slide, please. So we've been doing this for a couple of years, and we were able to get about 400 transplant recipients. And our findings, which I'm going to discuss today, but in case you want to read further, are published in 2 journals. So the first was Safety and Immunogenicity of Live Viral Vaccines in a Multi-Center Cohort of Pediatric Transplant Recipients. This can be found in JAMA Open. And then the follow-up study reporting 1-year outcome data was published in JAMA Pediatrics. And both of these are publicly available. And if you have any trouble accessing them, certainly let us know and we can just send you the PDF. Next slide. So before we get into who actually went into the study, I wanted to talk a little bit about what different centers allowed. So you can see that there's great variation. The majority, but not all centers, required the child to be a single organ transplant only. Centers differed in terms of how far out from transplant they wanted their patients to be. Likewise, centers varied in how far out from the latest rejection episode they wanted patients to be. EBV might be something that can drive your immune response, and centers differed in how low they felt the EBV needed to be in order to proceed with live vaccines. Next slide. Likewise, you can see that the lab values that centers required really varied. So certain centers looked at things like the absolute lymphocyte count, which can be found on your basic CBC, CD4 level, which is a marker of T cells, IgG level, and those all differed. And then likewise, centers differed in terms of what immunosuppression they were willing to vaccinate on. So some centers required their patients to only be on one immunosuppressive agent. There were different trough levels that people felt comfortable with. And finally, people felt comfortable with different additional immunosuppressive agents. Next slide. So who actually went into the study? So at the time that we did the publications, we had 383 pediatric transplant recipients who had received at least one post-transplant live vaccine. The majority of our initial studies were in liver transplant recipients, 97%, but we had a few children who had undergone kidney transplant and 2 children who had received both liver and kidney transplant. Really excited to say that 20 US centers participated in giving data to this study. And I really think, again, that speaks to how invested this community is, that people really wanted to find out the answer to this question. Some children only got MMR vaccines, some children only got VZV vaccines. The majority of children received both. So on average, when children got their first post-transplant vaccine, they were about 6 years out from having undergone their transplant. Next slide. The majority of children, greater than 90%, had low EBV levels, less than 2,000. This is interesting. The majority of children were on what we would define as low dose immunosuppression. And what we defined as low dose was that they were either on single dose therapy with either tacrolimus or sirolimus, which is also known as rapamycin, with recent troughs running less than 5, and just a little bit of steroids. But 34% of the population were on what we would consider medium or even high dose immunosuppression. 25 of the children were on MMF, which is also known as Cellcept, and 5 of the children were on azathioprine, which is also known as Imuran. Next slide. So what happened to this almost 400 children who received live vaccines? So the first slide that I'm showing you is their short-term immune response. So we gave the vaccine, and then 1 to 3 months later, we measured in their blood whether they had mounted antibodies that would suggest protection. So you can see that after between 1 and 3 vaccines, 71% of the patients had protective varicella zoster virus titers, 84% had positive measles titers, 83% had positive mumps titers, and 97% of the children mounted positive rubella titers. And I do want to highlight here that there are two kind of arms of the immune system. There's what we call the humoral arm, and that is where we make antibodies that help protect us from disease, and that's what we're measuring in this study. But there is also an arm of the immune system called the cellular immune system, and it's hard to measure that. The labs are very laboratory intensive and also very expensive, so we didn't measure that as part of this study. But I just say that to say that, let's say in the 30% of children who didn't have positive varicella titers, it is possible that they were still protected from varicella because they had cellular immune response. Next slide. So we then at 1 year looked to see if children retained or kept their protection. So of those children who were protected in the short term, 78% of them maintained protection for varicella, 92% maintained protection for measles, 72% maintained protection for mumps, and 96% still had protection for rubella. So looking at this, you would say that the majority of children who received vaccines, live vaccines after transplant, were able to mount a protective antibody response. Next slide. So one of the things I think you as parents and us as providers were most concerned about is adverse events, specifically serious adverse events. So of the nearly 400 children who got live vaccines, 5 of them, or approximately 1% of the population, did develop clinical varicella or chickenpox. These children all developed their chickenpox a week or more after getting their varicella zoster vaccine. All of the children resolved their infection within 7 days. 3 got antiviral meds, the other 4 got nothing. And interestingly, and not surprisingly, all of these children were on medium or high dose immunosuppression. One child had some swelling in a lymph node, kind of in the neck, cheek area that can be suspicious for mumps. So we put it on the slide. We didn't have any testing to suggest that the child definitively had mumps, and they got entirely better on their own. Importantly, there were no children who developed measles. And that's really important because we have no treatments for measles. And so whether you get it from the vaccine or you get it in the community, we don't have an antiviral or antibacterial or other medication to help stop that disease. Also importantly, there were no children who developed an episode of rejection or graft failure within a month of getting their vaccines. Next slide. So in conclusion, this work that we were able to do kind of with the help of the whole community and all the families who were willing to participate demonstrated that live vaccines can be safe and immunogenic, meaning hopefully protective after solid organ transplant, and would suggest that it's important to consider, and I might even say encourage these in a world with ongoing measles outbreaks. Children on higher level of immunosuppression than in initial clinical trials may also be able to safely receive these vaccines. Next slide. So we completed this work and we're kind of ready to stop the study, keep going with vaccinating. And that's when measles went crazy and it started popping up all over the United States in every state, and parents got really worried. And so what have we done? First of all, we reopened the database so that if there are additional liver patients who want to get their live vaccines, that we can collect information on them. When we talk about serious adverse events, they're likely to be 1 in 10,000, 1 in 100,000. And so in order to get what we call the power to detect those things, we need to collect information on more children. Likewise, we realized that probably liver families were not the only ones who were asking this question. And so we are currently collaborating with PHTS, which is the heart organization, and IROC, which is the kidney organization, to open our database so that we can start collecting information on pediatric kidney and heart transplants as well. We're also adding to the database collection forms to understand if transplant recipients have been exposed to measles and what happens to them, and are there any transplant recipients who, from the community, develop measles. And with that, I will hand it over to Anne.
Hi, everyone. It's such a pleasure to be here today, and thank you for joining us. So I'm going to give you just a little bit of a different slant, and that's basically how we started being able to do this clinically in heart transplant patients. And the reasons we decided to do it is, especially in heart, where we have a number of baby transplants, it's very hard to optimize pre-transplant immunizations in every patient, often related to age, how sick they are from a cardiac perspective, and how urgently sometimes they need transplant. Sometimes we just don't have enough time. And so they remain at risk of getting chickenpox or measles or some of those diseases. And we also felt strongly that providing this immunization will reduce the risk for them and the severity of getting one of these infections. We definitely felt it would reduce some patient and parent anxiety, and we saw that in our own patient population. And we felt it would decrease the need for and the cost of giving something once they were exposed to one of these illnesses, and decrease the number of days lost at school. Next slide. Thanks. So Lara already shared the IPTA consensus guidelines from 2019, and they came up with a list of what were considered to be safe patients. So they had to be well more than 2 months after rejection. They could be closely monitored. So we were able to put check marks next to all of those. One of them was more than 1 year after a liver or kidney transplant, as you've already heard. So obviously, since we were looking at heart transplant, that was not a criteria we were ever going to be able to meet. And there was some specific criteria for low-level immunosuppression as defined in the document. So there wasn't really a good way for us to just draw direct comparisons because our immunosuppression regimens were a bit different. And for example, the document pretty much said you shouldn't be giving it to anyone on MMF at the present time, at the time we had this discussion. Next slide. So we came up with our own way to look at kids from a risk stratification perspective, and the principle that we were giving thoughtful consideration to using those guidelines to develop a framework to give it to heart transplant patients. So we used all the same considerations: time post-transplant, their medications, their age, some of their immune testing, rejection guidelines. Next slide. And then we began to immunize our patients. So this is just real world experience. So for varicella, we've given it to 38 patients. When they were transplanted, the vast majority of them were less than a year of age. So you can see why they wouldn't have had these immunizations yet. And the range was 4 months to 1.5 years. And when we vaccinated them, their average age was about 11 years. So it was about 9 years post-transplant. And I've put the ranges there so that you can see. So these kids are pretty far in their transplant journey. And in terms of the meds that they were on, about 50% of them were on both tacrolimus and MMF, and about 44% were on tacrolimus alone. And then we had a very small number on tacrolimus and sirolimus and MMF. Our overall seroconversion rate, so before we vaccinated them, we tested everybody and they all had negative antibodies in their blood. And then after we vaccinated them, we tested again. So we tested in general about a year. I think our average duration post was just about 16 months. And about them, so 97% of the patients had developed antibodies against the chicken pox. So it gave us a very nice level of protection for these patients. Next slide. In terms of adverse events, the way that we did this is we immunized the kids in our clinic, and 3 weeks after the immunization, we phoned the families and said, "Did you notice anything?" Nobody phoned us to complain of anything, but we were trying to do due diligence. So 13 of the patients reported something. And they had to think back about it. So most of them were very mild. We had the patients count spots if they came up, but we have no way to know whether these were chickenpox spots. Nobody had vesicles, nobody had blisters. And so they would count any red spots on their body and report back to us 3 weeks later. So 10 of the patients had some kind of non-specific small red spots that went away by themselves. And 3 of the patients had a reaction at the site of the needle, like some kids do, where they got a bit of pain and a bit of redness and a bit of swelling. And no patient could develop chickenpox or fever or any systemic signs. And so with this experience, we felt the varicella vaccine can be given safely to pediatric heart transplant recipients with an excellent seroconversion rate and mild adverse events. And we've continued to offer it to our patients that are unvaccinated, in relation to never having had the vaccine before. Next slide. So then it made sense for us to go on next to MMR. So we've done 18 patients. We use the same criteria as our chickenpox patients. So in fact, it's the same group of patients that had baby transplants and never were able to get the immunization. The range that we immunize them has been between age 3 and 16 years. And again, it's about 50% tacrolimus and MMF and 45% tacrolimus. So far in these 18 patients, we've seen nothing. And we're still in the process of following these patients because the MMR vaccine we've been doing relatively recently within the last year. Of the patients that we have checked the serology, because we're waiting a year, we have had the vast majority of them come back positive from a serology perspective. I'll defer to Lara, but we worry less about positive serology in the long term in MMR because we know that they're keeping some memory in their body, and hopefully if they're ever exposed to these viruses, that memory will come out again, whether or not there's positive serology in their blood. And there is some evidence for that. And these particular kids, and I should have mentioned it for the varicella kids, have all received both doses of the vaccine. So we felt that that more than 50% of these patients had factors that had placed them in that orange or cautionary category for live vaccines, but that these findings supported liberalizing the current restrictive recommendations for live virus vaccines in pediatric heart transplant recipients. Next slide. And our overall observation is exactly what I said. So I just wanted to emphasize that again. There's no black and white for this, and that's why we're going to answer your questions. And every program's making their own decisions right now about how to move forward, but we do feel that the experience supports liberalizing the current recommendations. And with that, I'll hand it back over.
Sure. So some of the commonly asked questions I think that we may have collected actually from this group beforehand. So first of all, is there work being done in kidney or multi-organ recipients? So yes, initially when Lara and I started this, we did want to include kidney recipients. I think because we were working mainly through split, we just had a little bit more buy-in there, but we have a webinar coming up with the IROC community and providers. And a couple of weeks ago, we had a webinar with the heart community. And so I think that, yes, there's lots of work, and we are, like I said, collecting the data in the registry. We appreciate all of you parents being willing to allow us to put your children's data into that so that we can give families like you better information. We want to be able to say that we have hundreds of kids from all of the different organs and now thousands all together so that we really can give you strong recommendations. Next. How can patients and families advocate? So you all have really led the charge with this. I would say that what started all of this is families asking, I think my child needs to get live vaccines. I'm worried about them living without them. I want them to be able to live that normal life after transplant that you talked about. And normal life is airplanes and is college and is nursing school and all of the things. At this point, I think the process for you is to start by asking your local team. And the reason why I say that is because your local team knows your child the best. Every single child is very different, right? They have a different story. They've seen different medications. They had different complications. And so while Lara and Anne and I can talk about what we found in general, there may be a specific nuance about your child that would make your provider nervous, and that's worth having a conversation about. So that's ask questions about local processes. Certainly be willing to put your kids' data into the registry, and really we haven't seen any problems with that. Be willing to share your experience with other families who are going through this. I think it's one thing for the provider to say that they feel comfortable. I think it's another thing for parents to say that they've gone through it and that their child did fine. And I know that you all really support each other through social media and organizations like Transplant Families and Bear, so keep doing that. Just in terms of keeping your own child safe, if they are not immune, then you want to think about how to protect them. I'm a big believer that we don't do transplant to live in a bubble. The idea is to live a normal life. But if you're at a big crowded event where you know it's people coming from all over and your child is non-immune, maybe you want to throw a mask on them. Maybe when you're on the airplane, it makes you feel more comfortable to do that. I think those are all certainly reasonable. And then, you know, as we see outbreaks in different areas of the country, just be aware of what's going on in your area so that you can make good decisions and ask good questions. Next slide. So we wanted to keep this presentation short, and I'm glad that we finished at the 40-minute mark because we really want to hear questions from you, and I'm already seeing great ones in the chat. We're probably not going to be able to get into individual details about your child, but certainly willing to answer anything about measles, mumps, rubella, varicella, vaccination, and we all have different expertise, so we'll kind of jump in of the things we think are most, that we can best answer.
First of all, I want to give a huge thanks to Drs. Dipchand, Feldman, and Danziger-Isakov. Thank you for being here. This is, like I said, a long-standing thing that parents have been asking for. I'm going to use host privilege and ask the first question and maybe loop in another one. My son was, he got chickenpox at 7, and he was one of those that was one of the baby heart transplant recipients. And so he missed his first 2 weeks of first grade, which, you know, is better than, you know, far worse that can happen with these kind of situations. But like, he's 17 now, and we were wondering, how do you start that conversation with your provider? Who do you ask to, if he can measure titers, if this took for him, if it didn't? We have actually never followed up on this, and our poor kid, it took, like I said, his first 2 weeks of first grade, but he's fine now.
I'm sorry to hear he went through that. Happy to hear he came through it well. Great question. So I think each team has a little bit of a different dynamics of who your point person is, but you should really feel comfortable bringing this up with anyone on your team. So, you know, often I know transplant patients talk most frequently with their nurse or their transplant coordinator because that's the person that's calling you with your labs. but certainly your providers are also willing to chat with you about this. If you're a heart patient, talk to your cardiologist. If you're a liver patient, talk to your hepatologist. And then when you ask us hard questions that we don't know the answers to, because I get these all the time, then we reach out to our ID colleagues and email or call Lara or her colleagues around the country to really like join our expertise and pick our brain. So I think what I'm saying is don't feel embarrassed to bring this up. This is a very relevant question in today's world. You should not feel like you are disappointing or pushing buttons for your team. This is so relevant. I would be asking this if I were a parent.
If I could follow on, I will follow on with Dr. Warity's question. Did you have a baseline titers prior to the post-transplant live virus recommendation?
So I think what you're asking, so let me just broadly say, so there are some patients who never received vaccination pre-transplant because they were too young. And I think we usually assume that they're going to be negative, although it is possible that some people have a little bit of immunity because they've seen it somewhere in the world. So centers vary on whether they repeat your immune tests before transplant if you've gotten the vaccine. We know that certain children who are protected pre-transplant can lose that immunity when they go through transplant. So I definitely think it's relevant for anyone to get their titers checked at this point as like a pre. And then when parents agree, we give the vaccines. And then, yes, we check titers in the short term, so 1 to 3 months after, and then again at 1 year so that we can understand. I hope that answers the question.
I'll just add to that, just from a practical perspective, we are one of the centers that checks before we immunize anybody. And so if they have positive antibodies, then we take them off the list to be immunized.
Thank you so much. I will hand it over to Jen next for the question.
Yes, thank you. Good questions. I am going to throw a question here, and I did see it in the chat, and it was actually one of my questions too, in regards to kids that are on biologics for different types of therapeutics, especially kids that maybe have eosinophilic esophagitis. So using dupilumab or Dupixent, do you see anything in the future as far as looking into kids being allowed to receive live vaccines that have also those types of medicines as therapeutics to be able to receive those vaccines?
I'm happy to answer that. I think that this is something that's a really common question now. There's lots of discussion ongoing in multiple different areas of that I get asked about, and I'm sure other people get asked about which biologics is it okay to give live vaccines with, and which is it not? And it's something that people are actively looking at. I know there's a large discussion in the rheumatology group trying to figure out which of their biologics that they commonly use are what's the threshold for safety. I don't have an answer for you specifically about dupilumab, but there are other ones where we certainly have no restriction and allow live vaccines to go forward. There are some that we are more reluctant to do that, like interferon gamma inhibitors, TNF alpha inhibitors. Those have a different set of implications, and we generally don't use live vaccines with those patients. But there are some others like dabrafenib and some other things that we have done live vaccines in those patients without an issue. We just don't know all of it yet, so it's a question, and it depends on some of the other things, especially if you're talking about patients who have EOE and a transplant. Then we have to be cautious about that as well. But there's definitely interest in work moving forward in that area.
And I think I would add on to that, because we are moving forward with a couple of our patients who are on Dupixent, because so many kids have comorbidities, whether it's EOE, which maybe is even set off by the tacro that we have them, or eczema. Lots of our kids have this. I really believe in shared decision making, and families have to be part of this risk benefit too. Feels scary as a provider because we're the ones that are ultimately ordering the vaccine, and if something bad comes from it, it was under our order. But I feel if I share with you all of the risks and I talk about that, yeah, it's an increased risk with Dupixent, like I don't know the answer. If you as a mom feel that for your child getting vaccinated is really important, it's affecting how you live, then we do it and then we collect the information on it and it's a shared decision making.
I'll take that just one little step further. I completely agree with the shared decision making with the families, but I also think we have to remember if there's other teams involved, that we should include them as well. And the reason I say that is we've done a number of kids now and we feel quite comfortable. But for example, I had one little one who had celiac that was very difficult to manage. So we did speak with our GI team, or we actually encourage the family to as well. So though the child met our criteria for giving live vaccines because of the medications that team had her on, they didn't feel comfortable yet. And they said they'd reassess in about 6 months. And we've had that experience with a couple of our shared oncology patients as well. So I would encourage you to also consider that you should speak with your child's other teams to make sure they don't have a reason, even if from a transplant perspective, they're okay to move forward.
That really puts us as peace as parents to have the more the merrier. I'd like to remind everyone that there are materials referenced in the resources tab, and I'll move on to the next question by Cody Reynolds. What can parents do to influence other transplant families that may be unsure about getting their transplant child the MMR and Varicella series? My daughter completed the series from December and through March and was a success. Is there data that we can share?
Yeah, so certainly sharing your own experience is important, but I love that you want to share pooled experience. So the two papers that Lara and I referenced, which does report on those nearly 400 kids, those are publicly available. And so you can share those with families, you can share them on Facebook, people can find those, we can share them for you. And then I think Anne's work is going through the stages of presentation and then publication. And once it's in published form, then it will be available to share as well. All of our goal is to get this out to you guys. There's no reason to collect information just to collect it. It's really to educate the whole community, which is both providers and families. And we could certainly, as a follow-up, if there's a way for transplant families to post those two papers, I have no problem with that either, since they're publicly available.
We appreciate that. Thank you so much. I'll let Jen choose the next question.
All right. So the next question that I see is where any of these patients who received transplants as infants been vaccinated and then well into their adult years, so 15 to 20 years plus. And if so, what were the results? And if not, what would be the primary concern after many post-transplant years?
I can
Sorry.
only speak anecdotally to that. So we've had a couple of our young adults get vaccinated in relation to the jobs that they wanted. And certainly there wasn't anything untoward or unexpected. Our adult program asked us if we would have done it if they were like a month prior to transition, and we said yes. So then they went ahead and did it. I'm not sure, and Lara, you can speak to after from a heart perspective at least. There's not something that I would worry about as being different the longer you are post-transplant. It's all the same principles that matter.
Absolutely. You can get vaccinated at our center as early as a year post-transplant and as far out as 20, 25 years post-transplant. It doesn't impact our approach or our quest to ensure that everyone be protected, against these vaccine preventable illnesses. Now,
Great.
I will say one thing. If you have had chickenpox or had a chickenpox vaccine pre-transplant or chickenpox post-transplant, and you are over the age of 18, actually, and 18 or 19, you are eligible to receive a non-live vaccine called Shingrix, because that is an alternative option to boost your immunity if you have fallen below the level of detection of antibody detection. So that is something you can also ask your providers about if you are in that older age range and you have either gotten your chickenpox vaccine before transplant or you've had chickenpox naturally.
That's good to know. I will be asking next year when my son turns 18. All right, next question is from Stephen Whiteson. Is there any reason why IVIG is not chosen upon infection instead of risking a live vaccine?
I'm happy to answer that question. So IVIG is a great medication that we have at our disposal when someone is exposed to try to reduce their risk of getting disease. Once you have the disease, it doesn't work very well at preventing the disease from progressing. So it is not a treatment. It is more of a way to, if you have an early exposure and you have to get it within a short window after your exposure, in order for it to be effective. So it is not long lasting. It only, actually, if you're on chronic immunoglobulin therapy with IVIG, if you haven't had an infusion within 3 weeks, if you're on IV form, or if you haven't gotten recent subcutaneous dosing, then technically you need to get additional extra doses if you get exposed. So it doesn't last long because it doesn't stimulate the T cells, that cellular immunity, to try to remember what the vaccine is and create its own new antibody when you get exposed. So it's short-lived and it doesn't actually treat it once it's become an overwhelming infection.
Thank you so much.
So we're gonna, I know this probably sounds like rapid fire here, but we want to make sure we get all these answered as much as possible. Next question that I have is, what would the treatment be for a child who does get the measles if they're post-transplant, if there is no antiviral treatment option?
Treatment for measles is mainly supportive care. Most institutions will give you a dose of vitamin A. If you're a child, based on some studies that were done in the African continent for patients primarily who were vitamin A or nutritionally deficient, but most places will give a dose of vitamin A and provide supportive care. There are some experimental theoretical antivirals that people have tried or may try, but they are not part of the routine care for measles. It is really just a dose of vitamin A and supportive care. And that means fluids, oxygen, medications to bring the fever down, anything that, helps with pain, other things like that. And if they get an infection on top of their measles from having, a bacterial infection because they're in the hospital, then antibiotics. But antibiotics alone do not treat measles, and we don't really have a good antiviral to take care of measles, which is, I think, why many of us really want to protect kids so that if they do get exposed, they don't have to go through it, because measles is pretty miserable.
Clarifying. Thank you so much. Lena has a question. Is there a time after transplant that is safe to get live vaccines? Also, a time after rejection? Have you kind of determined those times?
So each center has their own policies or protocols of what they think the exact time is. As I showed you in the slides in Lara and I's study, it really varied. There were programs doing it short and doing it long. I would say the average, most people aren't going to be considering live vaccines until you're a year out from transplant. And you have to be a couple of months out from rejection. We don't want your immune system kind of dealing with that at the same time that we put the vaccines in. But the very specific time is going to be center dependent. As we get more and more numbers of patients in the registry, we may be able to start seeing some statistically relevant differences to say that there's a difference between 10 months and 14 months, but we don't have that yet.
Okay, thank you. We'll go on to the next one. Was the vaccine given in this study, was it altered or lowered in any way, shape, or form, or was it, given out in a, longer period of time, etc.?
So the vaccines in the studies were the same doses that are, commercially available. They were all given as part of routine vaccination. They're not modified in any way. And as far as the timing of them, that was dependent on each individual site. Most of them follow the parameters which are, you cannot give them they have to be at least 4 weeks apart when you give live vaccines. So other than that, some people got them 4 weeks apart, the first dose on week 0 and the second dose on week 4. Some of them, perhaps they weren't able to come into the clinic visit, or they had a family vacation that they wanted to go on, or they had school and they didn't want to miss anything. So some of them, got it 3 months later, and that any of those ways is entirely fine. We at our center, and I know that at the other centers as well, we try to work with our families and the patients to try to do this in a safe and convenient way. Not only do we give them at our center, but we also work with primary care providers out in the communities to allow patients to get their vaccines close at home, so that they do not have to travel to get a vaccine unless they're already coming here for another reason.
Yeah, I would echo that, especially as a center that takes care of kids from a 7-state region, that initially we did make people come to us because we wanted to have this risk-benefit conversation in person. We've now moved to doing that via telehealth. So I meet with each of our families to go over risk benefits. We don't want this to be a barrier. So I think that's an important thing. One thing I will say, your pediatrician has been trained correctly that they should not give you live vaccines after transplant. And so they're very careful about that. And so it often requires a member of our transplant team reaching out to them first to say, yes, we are giving approval for this individual child to get it. So don't just show up in your pediatrician's office. They will want a blessing from your transplant team, appropriately, as they should.
This is great. We have time for about 2 more questions, and any additional questions we will forward to our speakers and hopefully get some answers a little bit later. Molly asked, she says, thank you for doing this so much. As a mother of 2-year-old who has been transplanted at 6 months before she was able, oh, I'm sorry, the question went away. If you could ask that again. I will go on to the next question. I'm so sorry. How did the multi-organ transplant recipients do after receiving these vaccinations?
So we only had 2 kids who got liver kidney. They were not statistically different in their response. I think liver kidney, what's really important is how much immunosuppression you're not on, more than the fact that you got 2 organs. That would be very different than if there's somebody on this phone call whose child is going through a multi-visceral transplant where you're getting a small bowel, a liver, a pancreas, a kidney. Those children are very immunologically different and require different levels of immunosuppression. And we didn't have any of those in the study.
And Molly, we will get to your question later, but I'm going to give Jen last choice.
All right. So last question here is, what is the risk of infection for immunosuppressed kids, unvaccinated patients who have siblings that are receiving the MMR or chickenpox vaccine? I know we hear about shedding. So maybe you can kind of debunk some of that.
So there's not been a report that I'm aware of a transmission from a sibling to another child an immunocompromised child in the home. I think the most important thing is, keeping a close eye. Obviously, if someone has open lesions at the site of their varicella vaccine, they should be covered. And I would recommend the immunocompromised child not touch them. But otherwise, really the risk is much higher of not vaccinating the siblings, and because then they're going to bring those things home. And we know that once a child brings home chickenpox from school, they're going to share it in the house almost invariably. And every child who gets it after the first child in the house gets it tends to have a higher burden of infection, more spots, and it's just a little bit more miserable. So we really the risk of getting a vaccine for a sibling to giving that to the child who's immunocompromised is exceptionally low.
Thank you so much. I know Dr. Danziger-Isakov has to leave, but we are going to stay on for just a few more minutes for a few extra questions, and we will go ahead and get started. Amy, did you see anything in particular that you struck your interest for the questions?
Let me peruse through, and we will do our best to answer all questions, although Lara is such a resource, and every one of you has an ID expert at your center. And so your transplant team is definitely involved in conversations with them. So I see a question about the percentage of protection for vaccines in non-transplant kids. So I assume you mean healthy children. They're higher, but I would say that having the majority, so greater than 50%, but really for all of ours, greater than 70%, is a good level of protection. And again, to remember that even if you don't have those antibodies, your body may still have the memory to respond appropriately. So it's probably higher protection than the numbers we even gave. My son was 3 at transplant, received MMR and VZV, but has not received boosters, has a positive MMR titer. Are there fewer potential? Yes, I think that if you're getting a booster as opposed to your first round, it's probably a little bit safer and you're a little bit more likely to respond. With varicella, we do have a treatment. And so that for me is the less scary one, that if we somehow give your child the disease with the vaccine, we could treat them if they have varicella. So I think that would be appropriate to go forward. How do you advocate for your child to receive the vaccine when it is hospital policy to not vaccinate? So I think the first thing is maybe to bring our articles to your team and just share with them that I've seen this out there and I'm interested in exploring this. Have your providers reach out to Anne and me and Lara. We are trying really hard to have webinars and meetings and get other people engaged, but we also want to share our experience. I think recognize that just like for a parent, it's hard for something that's been such a historical black and white to get changed on you. It's hard for physicians too, because we just don't want to ever do any harm. But I think the thing that I've been posing to some of my colleagues that were a little bit later to accept is that if you say no to a vaccine and then that child goes and gets measles and has harm from the measles, that's essentially the same thing. You're kind of doing harm by not doing well. And so risk benefits have shifted than where they used to be. And so have a conversation and feel free to share our numbers. I would not say Amy and Lara and Anne say it's fine and I don't understand what's going on, but say I was on a really interesting webinar where it seemed like my child might actually meet criteria and other people have been doing this. Can we have a discussion?
Thank you, Amy. Oh, Dr. Dipchand must leave us now, but we still have Dr. Feldman with us for a few more minutes, and we will also bring on Jennifer's other half for Bear. Jordan can join us as well, and we'll answer a few more questions.
Hi, Jordan. Okay. Is it okay if I just keep going through?
Yeah, fire away.
Yeah, go for it, Dr. Feldman.
Okay. You said there is no treatment for measles. Is there a treatment for chickenpox? Yes, there's an antiviral medication called acyclovir that can be used. How would a transplant recipient be treated for measles and chickenpox if they had severe reactions to those vaccines? So I think it's important to clarify, is your child having a vaccine reaction, i.e. a fever or a rash that's not from getting the infection, that's just from having an immune response? That would be managed with Tylenol or Motrin, whatever your child is allowed to take. Differently, if they were to obtain the virus, then if they got measles, you would think about whether they need oral or IV antivirals. And this has never happened before, but if a transplant recipient got measles from the vaccine, then it would be the same thing as Dr. Danziger talked about if they got it from the community, about potentially giving a dose of vitamin A and supportive care. Oh, yes, this is a great question. I'm sure someone brought it up. What is relevant for oncology patients if they are done with chemo? So definitely you want this to be a joint decision. I am actually hearing that the oncologists are much more aggressive about having done this than we are. They often recommend people getting boosters after they've been through chemotherapy. Having had cancer is not a specific contraindication. We're still going to go that year post-transplant. So talk with both of your teams. If a vaccinated close contact of an unvaccinated transplant child is exposed and comes home, is there a risk through secondhand exposure? So again, this is my ID is not my expertise, transplant is, but I'm going to take a shot at this. So if an adult is fully vaccinated, their risk of acquiring measles, even if they're exposed, should be very low. It's not zero, but it's very low. So most of the time, even if they come home, they're not going to spread it because they're not a carrier of it. If they were the very small percent that got measles themselves, yes, then they could spread it to anybody. Okay, I think we did this one. We did this one. Was IVIG given concurrently with vaccination with any site? Not that I'm aware of, because these weren't children that were exposed to measles or varicella. These were just children who wanted to develop an immunity. Center-specific things, like I said, definitely talk to your team, educate them. In terms of research, wow, this is a loaded question right now. So I think that I would say that research has always been very competitive and challenging to get dollars. And certainly the priorities for research in this country may or may not be shifting with our change in government. Lara and I wanted initially to do this as a funded, but we really realized through this project that when there's an important clinical question, and parents and providers want to know the answer, we just do it. We get it done, right? And so people dedicated their time to enter data. Thankfully, it's not a high cost study because we can give the vaccine and draw the labs as part of clinical care. That's a little bit different than other research where somebody has to pay for either the labs or the medications. But for this vaccine research, I think we as a community can continue to do it unfunded. I think the heart organization and the kidney organization, we're helping them get set up. We're giving them education, sharing our protocols, sharing what's called our IRB, how we get consent. And so I'm hopeful that you're going to really start seeing that spread through the heart and kidney organizations. Is it reasonable to check for titers? Yeah, this is a great question. So I think yes, I think it's reasonable for anybody to ask for titers. Depending on your insurance and how your transplant coverage works, you may or may not get a bill for it. Usually your provider has absolutely no idea what you will be billed for. But if you're okay with it either way, there's no reason why a team would say that you shouldn't get titers drawn. We're not going to be ridiculous where we're drawing titers every month to make sure that we haven't lost immunity. But I think if it's not been checked in several years, it's reasonable in the middle of kind of an epidemic to ask for that. Given potential implications.
One more question and then wrap up.
Okay, let's see. So this is a good question about parent titers. So I recently learned we had a child who was exposed to measles, and I was taught that if the parents or the siblings have received their standard 2 doses of vaccine, so at age 1 and age 4, that person is considered immune, and the CDC does not recommend getting titers checked. So I think that answers that question. Heart transplant children is going to be all of what Anne talked about. It's a limited population, but she's starting the work, and so it's growing. Yes, multiple agents increase your amount of immune suppression. Talk to your team about it. Oh, and if your child has a known measles exposure, no, you don't want to take them immediately to get vaccinated. You want to let your team know that you're concerned. Hospitals right now have very clear protocols about what to do if there is an exposure in the hospital, if there is an exposure in the community. So you just want to call your team, and then they will get all the appropriate people involved. We are very heightened in our awareness of this. We don't want things to spread. So don't make this your burden to carry. Call your team and let them advise you.
Thank you, Dr. Feldman, so much. Thank you
Of
for
course.
doing, and I have to say thank you all for doing this research that's been unfunded on your own time and your own dollars, and just to answer and protect our children. This has been wonderful, and I can't thank you enough. Maybe we'll follow up and ask. I saw there was a question about educating other transplant teams. Maybe we can have something drawn up that parents can bring to their transplant teams to ask that question and start that conversation. Jen, would you like any closing thoughts?
No, I just want to thank Dr. Feldman for especially at the end there's some rapid fire answering. I really appreciate that and sticking through the end, and I do agree. I think maybe we could get together and maybe think about an FAQ or something that parents could bring with them to talk with their teams and really start having these robust conversations, because it is it's a shared decision between the patient and their physicians. So I want to thank everybody for coming and for joining us, and the partnership between Bear and transplant families as well. And with all the physicians, we couldn't do this without everybody here today. So I appreciate everybody greatly.
Thank you guys. Bye, everyone. Have a good afternoon.
Thank you,
Take
everyone.
care.